Good morning and welcome to our monthly live broadcast of the endovascular cases from Department of Endovascular Medicine here at Mount Sinai Hospital in New York City. I'm your moderator for the day, Vishal Kapoor, with my partner, Dr. Raman Sharma. And we'll be joined by a virtual co-host, Dr. David Song, who'll be taking any questions through the live chat box we have next to the YouTube link, which you'll be watching. So we're excited to present another case from the Mount Sinai Cath Lab headed by Dr. Christian and the team. Again, in continuation of our complexity of cases, different vascular beds, this time we are focusing above the diaphragm, involving a very interesting case of Dr. Krishnan and Dr. Guja of subclavian disease, which is more than a regular bread and butter. So without further ado, good morning, PK.
Hey, good morning. How are you? And welcome everyone to our webcast. We have a fantastic case here, very, very complex, and especially with decision making. I'm so happy to have all of you here to help us. We've got obviously Dr. Karthik Guja, the director of Mount Sinai South Nassau. We've got our endovascular fellow, Dr. Awad Jawed. We've got behind us, we've got Bray Lascano, our interventional nurse practitioner, and we've got Mark, we've got Sheba, Freddie, and of course Damien, who's always here with us. It's really, really an interesting case. A lot of discussion to be had, and hopefully we'll come to a solution that I think will help the patient. So without further ado, we're going to ask Dr. Awad, who's our fellow this year, to go ahead and present this case.
All right. Good morning. So we have a 74-year-old gentleman. He's been having dyspnea on exertion after 1 to 2 blocks and 1 flight of stairs that's been relieved by rest. So he has a past medical history of bypass grafting in 2018. So he had a LIMA-LAD and a left radial to OM. He also has a history of carotid stenosis with endarterectomy in 2016. He also has prostate cancer that's being treated with no metastasis. He's a former smoker, 20-pack year history. Current medications include aspirin, rosuvastatin, metoprolol, succinate, Entresto, and then leuprolide and bicalutamide for hormonal treatment for his prostate cancer. So imaging, initially he had an echo that showed EF of 45%. And then he had a stress test for symptoms that showed moderate anterior ischemia. He then underwent a coronary angiogram. It showed that the LIMA-LAD was patent, the left radial, the OM was patent, no significant disease in the RCA. However, a 45 millimeter gradient was noted across the left subclavian artery. So then he was referred to Dr. Guja, and then a repeat angiogram was done, and it showed a 80% calcified left subclavian stenosis, 80% calcified ostial left vertebral stenosis, and no significant carotid stenosis bilaterally. And so these were the images from the angiogram. And you can note the tight stenosis in the subclavian. All right.
Go ahead.
Okay. Yeah, and so just before we start, we're the ACC guidelines, they don't mention much about indications for subclavian stenting, but these are from the ESC guidelines. So it's 2B indication to do endovascular because of lower complication rates. And also, it's a 2A in this situation because patient has its internal mammary artery grafted to the coronaries with evidence of myocardial ischemia. So these are the indications for the procedure.
So it's a great case. I just want to, before we get to Karthik again, because he knows the patient the best, I want to just introduce a new thing that we're trying. There's been a lot of information or requests from you guys for more communication with the moderators. Obviously, the moderators are very busy because obviously they're moderating the case and answering our questions and creating discussion. So we've created Dr. David Song as a virtual moderator, which I think is a fantastic opportunity for those out there to go ahead and ask any questions. What Dr. Song will do is, if there's any particular questions that he wants to relay to the team, he'll just, I guess, ask interruption of Dr. Sharma and Dr. Kapoor or us, and then go ahead and just read the question to go ahead and help facilitate the discussion. I think there's a nice way of doing it. We always get your emails afterwards, and I thought that this would be something that would be very good to have it during live. And obviously, it's the first time. It may not take off because we didn't really announce it, but I think we're going to start this going forward for the next year and see how it goes and how the response is. So I'm sorry about that interruption, Karthik. Any other history or
I think
anything you want to give us?
I think Awad was nailed it actually. That's exactly the story with him. I think it's just the complexity of the lesion and the closeness the lesion is with. It's pretty close to the lima as well as the vertebral. And the only thing I think adding is the vertebral is a dominant vertebral. The right vertebral is non-dominant, and the posterior circulation is dependent completely on the left vertebral artery, and it gives both the PCAs, and the carotids on both sides don't supply anything to the posterior circulation.
Okay.
I think that's a very important point that Karthik got, especially with the intervention aspect when PK and Raman and everybody starts to talk about is we always miss, we are obviously focused on the subclavian part of it, but we always have to consider how the circulation to the brain is dependent on the vessels that are supplying, especially like Karthik talked about, the vertebral dominance will play a big part. And with the history, I mean, the patient as being a vasculopath, we should know the anatomy of the brain and the circulatory status before we start doing interventions, because God forbid if anything is there, we should already have some baseline drawn in. So I think that's very important that Karthik mentioned about the not only the cardiac pains, which Awad mentioned, but the circulation to the brain.
Yeah, I mean, the exact same concept, but just on the flip side of it, right? If we see that this is a non-dominant vert that does not really supply much of the posterior circulation, that actually makes your entire treatment algorithm relatively much easier.
Definitely.
Obviously, you can't be very aggressive and say, I'm just going to cover it and call it a day. But the decision and points about having a stent, even if it's a self-expanding, non-covered stent, at least you feel less worried about its impact on the posterior circulation. But that being said, I think this is a good point to start to look at some more pictures. So we have a 2.5 arch.
Yeah, I mean, the arch is not a big deal. I mean, we just did this just to get an idea of exactly where the subclavian takeoff was. Little bovine touch to it. So we went ahead and engaged this with a Lima catheter, and you can see the vert fills immediately. But that's fine. I'm not really, I mean, that's one of the things we have to consider. Then obviously there's not a good picture. Then we went ahead with a 90 centimeter sheath, put a supercore wire across, and then you can see that, again, I want everybody to remember the syndrome we're treating. The syndrome we're treating is Lima-Ischemia, not vertebral steel. So I think you need to really focus on where the lesion is. So what we've done is you can see, maybe, can you show the hemodynamics? You can see the hemodynamics are up on the screen, and you can see there is a significant resting gradient. So what I've done here is zeroed both. I've got a straight tip catheter across all the way down into the excuse me, Robert axillary. And so now we've zeroed both, and now you can see you have a significant gradient.
Wow.
And what I've done is I've just gone on roadmap here, and you really can't see. You can kind of see my catheter floating there. I don't know if you guys can see it. And I'm just going to do a little pullback for us. And then we can see where the gradient is. So here we're just going to do a straight pullback, and I'm really concentrating on where the gradient changes. So as the catheter is coming back, I just want you to watch as it gets to the lima, right, which is right about, we're getting around the lima there, and now we're across the lima, and there's still a significant gradient. You see that? Yeah. And now we're going to come across this, and that's where your gradient changes. Yeah. So now the case is a different case, right? So landing zone becomes more proximal across the vert rather than across the lima, and now you don't have to touch the ostium of the lima because you don't have a gradient. So what normally, when you look at an angiogram like this as an interventionalist, all of us are interventionalists in this room, is that you'll say, oh wow, he's got vertebral disease. I mean, he's got subclavian disease that involves both the vert and the lima, but the actual significant lesion is actually the one across that vert. So I would not even try to touch that lima because obviously you're complicating things even more. So now the question is, now you need to interrogate the ostium of the vert. So the idea here is this is obviously a little bit of a foreshortened view. So we'll go to another view here to show you a few other things. We can actually remove this catheter. It's no big deal now. Okay. So we're going to go to an LAO caudal. And look at the vertebral
Carotid, do we
ostium.
have a-
Careful.
We have a brachial axis,
Yeah, I was gonna
Vishal.
say,
I was just
yes.
about to tell you
Yeah.
that because patient's radial was used for bypass.
Correct.
So we have
Owen graft, yeah.
a 4-5 slender in the left brachial.
Yeah, I mean, the idea here is, not to get crazy. That's the whole idea. The idea is, what do we need to do? What do we not need to do? We've done a bit of these type of cases, not very often, obviously, as you can imagine. But here you can see that the vert ostium is involved, and it's a very, very tortuous ostium. So the question is, the idea is, well, what are the choices of doing this? And I think the question is, do you protect the vert with the wire? Do you follow the coronary technique or not? And then we'll do it. I want to take a little bit better picture here. Watch this here. And a little bit more cranial. Actually, a little more caudal may be better. Caudal may foreshorten. Sir, take a deep breath in. And hold your breath, sir.
Given that angulation, maybe actually going more LAO would actually help.
Yeah.
Not there. Yeah.
That's a better picture. So now you can see. So now what we're going to do is we're going to put an 014 wire down, and we're going to IVUS first. So can I have a run through?
Yeah, I think you're right. I mean, the ostium of the vertebral is involved, and it's a dominant vertebral. But I think, like you rightly said, the LIMA is technically, from a hemodynamic perspective, away from the lesion. So if we can almost, which I'm sure we can, is trying to accurately place the stent. The only thing we really need to be concerned about is the vertebral. I think we can still, I don't know how aggressive you want to be by putting wire down the vertebral versus putting a wire down the LIMA as a protective measure, or go from there. I think that's a strategy based on what your feeling is about the takeoff. The issue, like you said, is vertebral takeoff is very tortuous and calcified. So if we put a wire up front, I think it'll save us the day later on. But at the same time, we can also see after your pre-definitive therapy, meaning whatever plaque modification you want to do, you can assess it and then maybe try to poke around the vertebral if there's a compromise to the ostium. I think we could go both ways. Raman, what's your thought?
Yeah. I mean, I think there are three ways you can do this. Say I'm going to do no protection at all, which could be justified considering the overall dimension of the vertebral artery. Then with your brachial axis, option 2, go with just wire protection, or option 3, go with a balloon protection to protect.
Patients having chest pain.
Obviously, with the other two,
chest pain
protective mechanisms, then you have to worry about what's going to happen with the severe angulation. Can you dissect the ostium and then make the simple case into a very
another run through, guys?
You're having some chest pain.
Yeah, I think that's a good point. And just to throw in some more
that's because
turns
of the
and twists and a caveat, if you're wiring the vertebral, is there any role of putting a filter up
because
there?
of the diapic.
Yeah.
If you put a wire there, you can have a wire with a filter sitting up there. I don't know.
I think in a different case where there was a little bit less angulation proximally, especially if there was more of a atherosclerotic component. This looks like just like a giant rock.
Correct.
That goes from the proximal ostium of the vertebral to just that segment of the subclavian between the vertebral and the LIMA. I'm a little bit less worried about any kind of embolic disease going north. Down the arm, yeah, maybe, but that's not going to be of any clinical sequelae.
Yeah, I think this is like a good talking case where planning is the main driver force for the determinant of the success of the case. I mean, technically, you could say, okay, I'm going to do my shockwave, PTA, self-expanding, like we talked about, non-covered getaway. But I think we have to be aware or cognizant of the fact that there are multiple other things that could happen on the site: LIMA, vertebral, both, none, or one. So,
so you could see the wire flew up the vertebral. So I'm just going to keep the wire in that segment there, and then now.
So you are planning to keep a wire in the vertebral. That's the goal.
I don't want to, but I have because the wire went. I'm doing the old.
It's a sign.
It's the old sign.
That really does speak to the overall, the degree of stenosis from the vertebral. If a wire will just go there so freely, maybe that disease is not as much.
Yeah, no, Raman, the vertebral is very big, and the tortuosity, I think, is very favorable towards the vertebral.
No, I think Robin's point is right. I mean, you may be right that it's just able to fly through. But at the same time, I think that it went. I took it. It's a safe wire. I'm keeping it below the V. Right, I'll keep it right there. the petrous portion, and just to have the wire there. And remember, we have ACT. We're having the ACT over 300 at this stage. We're just going to IVUS. I want to get the morphology of the lesion and then discuss, and then have our fellow make his presentation, and then we'll discuss what we're going to do. So we're not going to give any more dye. He keeps having chest pain every time we inject, so maybe because of spasm in the coronary. So what I'm going to do is just go ahead and just do a quick IVUS of this lesion, and then we'll take a decision on what we think. I have my ideas right now. I'm curious what you guys are going to think, but let's see what we come to as a consensus.
I think the complexity comes is if the lesion extends to the level of the lima.
Correct.
Well, we know it's not significant, so it doesn't matter.
No, but
From angiographically, it might, right. From an IVUS perspective, you might see an extension of lesion into the lima.
So there's our go with the IVUS live, guys, for us.
Hold on.
Can
We don't have
see
this.
the IVUS, please?
We don't have the screen on yet. Yeah.
Can you adjust the image, please, so they can see better?
Yeah, 60.
So gain to 60, please. Thank you. Okay. Is that good, guys? Can you see well?
Yeah.
Okay. I'm going to do a quick pullback. So that's the lima. Not so bad. There's your lima. Okay. You have a nice lumen. And then now you got the lesion. Look at that. Oh, look at that. Oh, look at that. Oh, there you go. That's right after the vert. The vert, you see the marker of the vert? Yeah. It's right after the vert.
It extends all the way right before
all the way across the vert.
That's your.
And now you're back to normal.
Yeah.
All right. So now we're done. So now you've seen the morphology of the lesion.
I think this is important to look at. You see our takeoff of the lima here. The ostium of the lima is not compromised at all. And then, where did it go? If you look at just a couple frames now proximal to the lima, there is disease.
Definitely.
And it extends all the way across. So now we can say that there is probably 1 millimeter or 2, maybe 3 if we're lucky, between the end of the lesion to where the lima takes off.
Yeah.
So now, I mean, I think we all agree that a covered stent is not going to be a part of this conversation. But what kind of self-expanding stent, or non-covered stent, would you be considering?
Or Raman, I mean, the question here is, we've got so much calcium. I mean, we know lithotripsy embolization with lithotripsy is very rare. Do we expand it to reduce the gradient and not stent it if we can not have a dissection? So I wanted to measure this. So Karthik, of course, doing the right thing, measuring our thing, getting us a vessel diameter. Once we have a vessel diameter, proximal or distal, I think proximal will be bigger. I'd rather get the distal vessel diameter to kind of undersize my balloon a little bit and try to get rid of that gradient, because I don't want to go too large here and obviously plaque shift into that vert. So this is the idea. So right now it's about a 5 or a 6? It's bigger?
No, it's 10.
No,
it's a 10.
Okay.
That's your proximal.
I think this is
I was wishing it to be a 5, you know?
Change your,
No, I think this is an excellent example of how physiology matches the anatomy, where you have the lesion, and PK clearly showed on his gradient pullback very nicely of where physiologically the lesion starts. So I think in this case, the anatomy matches the physiology, which is good for us. And like you talked about, Raman, the lima technically is out of the picture. It's more about what we do with the vertebral, if anything. So I think, like I said, we probably, like PK talked about, doing some plaque modification with lithotripsy,
PK even distally,
trying to
it's
get
about
luminal
9.
gain, see how your vertebral looks after, of course, being the focus on the subclavian, and then you can decide, do I need to stent it versus, like I said, leave it and go from there. I don't know. That'll be a decision depending on what happens after step 1.
Is it diluted?
No short?
Yeah. I would say this. I mean, like, this is
All right, 680. We'll hang it out.
9-10 millimeter diameter. This is the more distal subclavian.
Correct.
Is that correct?
This is the distal subclavian.
Yeah. So this is, even if we do end up stenting, these are open cell, larger cell struts. I mean,
It should be okay.
yeah. There's going to be no compromise to the vert if we go
So-
across.
So
I will say, the addition of treatment with IVL, I think, is definitely paramount. We see the severe degree of calcium.
So
I'll argue that. Yeah, sorry. Just want to
Sorry, go ahead.
Yeah, I would say that in this scenario, oddly enough, even though this is a relatively complex anatomy, this is probably one of the best anatomies that he will ever have to get this treated. In a sense, we're trying to changing it now with the stent may make any further, hopefully, re-interventions unnecessary. Whereas if we do a PTA, we don't know what dissections are going to be healing, how they're going to be healing. Maybe this is a good time for sending across.
I think that's a very good point, especially the chances of intervention of LIMA are much
low.
higher than chance of intervention of vertebral. And then we obviously also know from our cornea, I mean, of course, it's probably just transferring and being an analogy saying, even if there's a pinch of the vessel, we know there's enough blood flow not to have a physiological compromise. So unless you really see a 99% post-lithotripsy that the wort is collapsed, I think even if you see a little bit more narrowing than what it is right now, it won't physiologically affect your circulation of the brain. So you should be able to stent it with an open cell, non-covered system, thereby preventing any dissection of flaps, giving it your luminal gain and patency while not compromising the LIMA blood flow. So I think we could meet all our goals, hopefully with that strategy. But again, let's see how the lithotripsy works, and we go from there.
What size do you have?
Yeah,
we grossly undersized to a 6. Again, saying that
you did.
I did.
Me and Raman.
Yeah.
No,
Making contact with the blood.
I know.
Exactly. So
The RBC
This is 7,
more
I
than the
think.
wall.
7, right?
that's a 6. So what I want to do is, I just want to start with the 6. I don't mind spending the extra money here, because I really want to do it properly. So what I want to do is, so now we're just I want to stay away from that LIMA, which I don't see in this picture here. Hold on.
To go aerial.
It's RAL cranial
You want
here.
to do the radial? Put a catheter from the radial and shoot it?
No, I think this is better. Because right now we have that as a backup, just in case we need to stent the vert. There it is. There's the LIMA. Okay, good. All right, ready?
Put this on there.
So, Raman, sorry, I didn't want to interrupt you. I was trying to talk to Damien, not you.
Yeah, and also in this case, I guess one thing about the lithotripsy is we don't want to cross into the LIMA side, and we obviously know the one we have right now, the maximum emitters or the maximum strength of the emitters are in the center. But in this case, we won't be able to center unless PK is trying to, because his underside is he's comfortable crossing over across the LIMA, but that's another one thing to consider. If you want the maximum emitters, then you have to cross over.
Just put the catheter there. Easy enough.
But a 6 I think should be fine. Should not have any effect on the distal portion
I don't
because
want
we're
to
undersized.
engage the LIMA here. All right, let's
No,
see.
you don't have to
Well,
engage.
you can
Just
say
put it straight.
that
We have
seven.
angled the
I
temple.
was gonna say.
But I'll make the argument.
7
I don't
for
think,
sure.
I don't think a 7, 7, 5, 8 even going at that low pressure inflation is really going to do much issue. I'll actually make an argument that it may actually be better to put the balloon actually a little bit further since it's more of a straighter segment.
Yeah.
It's better to inflate it and not in that purely angulated area, because then even at the low pressure, you may actually end up still getting a dissection.
Because what's going to happen is if you do the lithotripsy part, you still have to go in and use another balloon to post-dilate it because it's going to be undersized. So if you use a 7 or an 8 or...
No,
then
it's
it would have
okay.
given you...
I agree with you. I mean, you guys want to kill everything with one bullet here. I think in this case, I think for sure we need a little bit more conservative approach. So what I'm going to do is I'm going to do a 6, and then I'm going to make a decision. We're across the LIMA here. This is the question I want to ask you, whether we go across the LIMA to a normal segment versus...
Yeah, I think for a 6er balloon, I think with the IVUS findings we have, we should be okay going across the LIMA. A little bit more aggressive balloon I would have been more conservative and pulled it back. But yeah, 6er, I think we should be fine. But what do you think?
Yeah, I mean, I think it's that same point. Where will the flexion of the native vessel be the highest stress point when you inflate that balloon? That's going to be at that proximal segment before the LIMA. So you may actually be safer sending the balloon a little bit further to have the proximal end of the balloon actually, be further in.
Right, I agree.
Okay.
So let's see how the way balloon behaves.
Lithotripsy. Start. Might have chest pain, guys.
Just kind of dog boning.
It is a super tight, super calcified lesion.
Okay.
Again, 6.
Yeah, this might do it.
Floor. 7 chest pain. 7, a little bit of chest pain.
Yeah. Now see the neck. This is much better than the first inflation. Yeah. Yeah, I mean, that's again a good sign that at least the balloon is expanded well, and the lithotripsy hopefully has modified the plaque good enough. And you might even see a gradient just go away if we do the rerun study, which I think it's just more academic than anything else. But yeah, definitely you're going to see plaque change, which he's going to probably eye us and get a better idea of what the expansion is.
We have a brachial sheet, so
we can do a simultaneous pressure. Yeah.
Yeah.
The wire came out of the vert here. That's fine. That may be a good sign. Walk it out. The wire popped out.
You want to just put the sheet in a little?
There you go. Good.
Bit in.
That's fine. It's fine.
Do you guys go above the 4 and 6, considering the diameter of the vessel?
Not in ostium, PK.
Huh? What's that?
You're not in ostium.
That's okay. I'm okay.
Oh, he wants to engage it. Yeah.
We'll retrack it in. Okay. Push forward. Good. Watch the sheet. We're out of the ostium. So fine. We're out of the ostium. We fell out with the 014 wire, which is fine. Because we have a wire across, we can always exchange. I'm not worried about it. Just take a shot here.
Okay.
Okay.
We're not going to see now.
No, we're not going to see much. All right, give us a vert tip catheter here, guys.
Yeah.
We're just going to change. We're just going to change this up.
Up there could
Well, we tried. It still slipped out. Here you go, brother.
Okay.
Take this wire for now. So we're just going to change out for an 035, put a dilator in and go in and take a picture.
So the gradient has reduced.
The gradient is definitely reduced. So again, like now it's about a 20 millimeter gradient. So we will definitely take a better picture here. So okay, in the meantime, while I do this change, why can't we go to Dr. Awad to talk about his well-prepared thing?
Sure. Let me get this.
Might want to pull back.
Can you see the slides?
A little bit.
Not yet.
Okay.
Can we have the slides on?
035 Supercore, guys.
I have it.
Can you put the slides up for Dr.
on,
Awad?
please? Yeah. All right. Now we see.
Busy slide.
Okay. Let me see. It goes back.
Summary slide.
Okay.
Well, that was
All
his
right.
opening
So,
slide.
Dr. Krishnan just asked me to look up some literature about IVL for subclavian lesion, and basically it's case reports that we have. So this was just a summary of about 12 case reports at different institutions, and they've shown success with the IVL for subclavian lesions, mostly with the self-expanding stents. And then also just a little bit of information about vertebral artery stenosis. So this was a summary of 3 randomized trials of stenting versus medical therapy alone for symptomatic vertebral artery stenosis. And across these 3 RCTs included about 168 patients, and more than 300 patients. 168 patients were randomly assigned to medical therapy, and 186 to stenting. And basically, over follow-up, there wasn't any significant difference between the stenting group and the medical therapy group. Yeah, that's all I have.
Oh, wow.
Yeah,
okay. That's a very small presentation. Okay. Yeah. Okay. Well. I guess.
Very, very few words.
We couldn't even check our text messages. Couldn't reply to any.
Yeah. So can we put up that slide with the IVL? Yeah. Because obviously that's the game changer in this case. Hopefully, with what we talked about, and I think the issue here is with the IVL. Is what's going to really help us to decide how we did this. Okay, I should be across now.
Yeah.
Oh, that's
And team, we actually have a question from chat that I just want to see what your all's thoughts are on.
Okay, good. Now we're
In institutions that may not have IVL, what do you think about pure PTA alone with a covered stent in this particular case, is what chat is asking.
I'll let the moderators handle that one.
Yeah, I think that's, I think, first of all, in an institution that is tackling cases like this, to not have a covered stent, I think in and of itself is a little bit of a problem. Because these kind of lesions in this size, proximal subclavians, iliac, you need to be able to have the bailout stenting, which in some cases is the destination therapy.
712.
You need to have that in your closet. You can't not have it available and then elect to do cases like this or iliacs. That's a point on the side.
Hold your breath, sir.
The next thing is that PTA alone without any plaque modification, you'll run the risk of creating serious issues just because you have to go very, very high pressure. This is not soft atherosclerotic plaque we saw in the IVUS. This is a giant rock. You can touch it with your hands. It's very, very hard. So I think you'll definitely run the risk of creating some further complications, which will likely necessitate a covered stent. That being said, the last thing, let's just say you decide to do a PTA safely somehow, but then you want to decide. The question was again just to do a covered stent.
Yeah, with the PTA.
Just PTA?
Breathe normal.
I think it's going to be tough. That's why it goes back to my first statement saying planning of the case is the most essential part in this case. And if you are planning this case elective, then you should have lithotripsy as an option. Otherwise, you're really binding your hands and you're jumping off the plane without much support, because at least lithotripsy will do some plaque modification. Again, every case is dependent, and you can still have dissection with lithotripsy. I'm not saying it's safe, but at least from the study perspective, it showed 77% less dissection, not in subclavians, but the vascular bed. So what I'm trying to say is lithotripsy, like Raman is talking about, gives us the luminal gain with significantly decreased chances of dissection, thereby not committing ourselves to our covered stent, but keeping the other options open as well. Starting from plain old PTA, which nobody likes it, but if it needs to be done, we do it. Plus adding an open cell self-expanding or a balloon expandable stent. I'm not in a favor of covered stents in this case, because I know that vertebral is dominant. I will really try to avoid it, but God forbid, if I need to, then I have to. Then I have to compromise, but stay away from covered stents in as much as possible, especially with the vertebral involvement. It's just not the best, not the good final strategy if opted to be. Yeah, PK, what's your thought? I know you're looking at it from all the angles.
Yeah,
it looks better. The flow looks better.
Well, the gradient is definitely better,
right?
But the question
is still there.
The question is, do we balloon it again and try to get rid of the gradient and leave it with a balloon angioplasty? Is what I'm thinking. I mean, if I can balloon
you want to go up on you want to spend a little bit of extra money, use a bigger shockwave?
I think we've cracked the calcium for sure. I'm not worried about that. I think we've cracked it. Karthik is coming with a wire.
My only question is, if you want a PTA, I'm sure you're going to use a bigger size, at least like an 8-toe balloon to do a PTA. Why not use the shockwave 8-toe and do a PTA and have a little bit of a lithotripsy component to it?
I didn't even get out of catheter yet.
Oh, no. I'm just saying I just wanted to see where the wire is. That's all. That's fine. Okay, now. So we're just going to take our LIMA catheter and just place it inside into the LIMA, or put a wire in the LIMA just to see where the LIMA is, and take a picture from both sides. I think that should be good. A little bit further. Yeah. Okay. Take a picture from both sides here, and then see whether we can identify whether we have a landing zone, and then decide.
I think that's the $1 million question. You're right.
I mean, to me, I think angioplasty is underutilized. Obviously Abu Rama and the guys actually did angioplasty for many years. Angioplasty has been studied in the subclavian. I was hoping Awad would do a little research on subclavian and figure out the patency. But the Shady Side registry is there, the Ashna registry is there as well, all for subclavian disease, and all of them, but none of them have studied this scenario, which is exactly what we're concerned with, right? Which is with the vert involvement. So the idea here is, what are we doing here, and how do we deal with this? And are the patencies going to be good enough to leave it with this? I don't want to use a drug-coated balloon. Obviously, it's not been studied in this area. There's an embolic potential with all of the excipients and all that. So I don't want to use that. So the idea here would be either with a balloon angioplasty or something. He's sleeping now, so Might be a lot of breathing here. No. Yeah, I'm just going to go down a little bit now.
Yeah, I think balloon angioplasty has always been an option. We actually did a case 1 month ago where we had to do just balloon angioplasty purely based on the sizing. The vessel size was 14 on that guy, and we could not find a stent anywhere which would be either balloon expandable or, and it had to be non-covered as well because of this complexity. And we just did a PTA and left it, and the patient has been doing well since then. I mean, again, I don't know the long term. It's just anecdotal. One case from my side. Raman will have one case to do it, but yeah, I mean, like you said, these big vessels, PTA alone will, if it gets the gradient off, like I said, which is our final goal, is to get the gradient off and have better flow down the vessels, then it might work. It's just the comfort zone of how well you want to leave the PTA. If you do,
I think one of the things we need to do is, I personally think we'll go with a bigger balloon here, or maybe, rather than do Serenator or something like that, go with a 7.0. Regular, balloon and just expand it, or maybe a Serenator is not a bad idea, but the lengths of the Serenator are too long. That's the problem here. The idea would be do we cut it and leave it is the question,
Can I throw in an 8/20 shockwave in there?
Yeah, I'm just gonna. I'm gonna say this one more time that we have IVUS evidence,
correct,
that the LIMA is not involved. There are a few millimeters of the subclavian before the ostium of the LIMA where there is no disease.
Mm-hmm.
We have a clear landing zone, and the vert is a huge vessel. I would still argue go with a short, a balloon expandable, non-covered stent. And now if you even have a wire going down the LIMA, you have another.
That's why we did that.
Very clear guide as far as where your stent should go.
I don't disagree with you that putting a balloon expandable stent is the right thing. I'm not saying no. I'm thinking right now the question is, do we need to stent and jail the vertebral? That's what I'm concerned. But to me, 100%, if you're going to stent, I think the idea is it's all about gradients. And I agree that we're protecting the LIMA here just in case we decide to stent. But the idea, for me, is just the worry of, can I get a better balloon result and just leave him with a 5 millimeter gradient and just let it go? We've already shocked him. We've already ruptured the calcium. So do we just go with a 7.0 Viatrac or something like that?
But that's the exact reason I'm trying to propose on a bigger size shockwave.
Pull back. Move.
Because of doing both your PTA, which you want to do, and add a little bit more lithotripsy to it. I mean, that's the only reason I'm saying about a bigger size shockwave. Like I said, it will do its PTA action as well. And at the same time, hopefully crack more calcium with better contact with the vessel, both distally and proximally. So I agree with the PTA part. I'm just trying to, that's the reason I was talking about an 8/20 lithotripsy balloon, which will cover enough.
I don't think we have an 8/20, do we? 8/20 lithotripsy?
Yeah. We have 8.0, 9.0s, we have it.
Huh?
But that's 8 French.
Shockwave.
8.0 goes through a 7 French.
All right, so we're going to...
9.0 goes through a bigger one. 8.0 goes through a 7 French.
8, no, we only have 60. We don't have 20.
All right, well.
We don't have 20 anywhere in the hospital?
So Vishal, if you see the gradient, right, they're back to what we were. I think I agree with Raman in this.
No, but the reason we're back to there is because the balloon was significantly undersized.
Yeah.
No, but the question is the gradients went and the gradients came back. I understand
because it's undersized. That's
Give me the 8. Let's
60 is too long.
Well, we did the 60 with the other one, and it's fine. No, we'll change out. All right, so I agree with you. I think we have to make and for the audience at home, you see the difficulty in this decision, and that's why we did it live. I mean, 8/60. So I don't want to stent. So that's my personal bias here. If I have to, I will. So I am going to go with an 8.0 lithotripsy, and then which is also, by the way, severely undersized.
Correct.
And then we're gonna take a look whether we have to do a short 9.0 balloon at the level of that to get rid of the gradient. So we're gonna change out this wire. So again,
that's the reason I was following a PK's thought process. Like you said, if he wants to do PTA, then hopefully, again, this is all, like you said, this is not studying the subclavian, but theoretically, if we have a little bit bigger size lithotripsy balloon, then the chances of dissection are relatively lesser, thereby giving us more comfort in leaving the PTA only therapy in this case.
I don't agree that the chances of dissection are a little bit less. I know when the disrupt PAD dissection rates were low, but this lesion was not
That's
studied.
what I'm saying. It's not studied. That's my first
to
statement.
me,
This lesion is exactly at an angle.
Correct.
It's
Yeah.
at the flexion point.
Yeah.
A longer balloon is going to have a higher risk of creating dissections proximally and distally. A shorter
My
balloon
concern
body,
is the dissection going to go into the
vert.
towards the lima, and
Yeah.
now we have to
Lima.
stent across
but
the
wait,
lima.
but
That's my biggest concern.
So the point is, you guys are saying just stent across
Just
the vert and jail the vert.
just stent across the word, jail the word, and then just
100%.
balloon it. That's it. It's
Dude,
because we're
I'm
doing
with
it
you.
for the sake of lima, not for the sake of word. And the word looks like it's okay, right? We did a shockwave across
No,
it.
but the gradient is still there. That's
No,
my point. The
that's what I'm
gradient is
saying.
still
Like
40.
stent it. Like my concern is we use a 8O balloon, and if the dissection plane goes through the lima, now we are defeating the whole purpose. Now we have to stent across the lima.
The question is, if we stent it across the lima, what's going to happen is, Give me the run through
Stent
wire.
across the word. you mean.
there's-
Stent across the
Stent across
vert is
the
this. Yeah, you might not be able to expand the stent because of the
Yeah, no,
calcium.
you have to prep the lesion before you put the stent
No,
in. That's for sure.
Yeah, the own for-
Otherwise, we'll
Run
end up
through.
in more.
All right,
we'll not get a good luminal gain.
So I'm going to hang the balloon out into the aorta here. I think we'll be fine. Let's see. We didn't dissect, and it's still undersized. It's 11O vessel. I think we'll be okay. All right.
Yeah. No, I agree. I mean, if Raman and Karthik want to stent it, we still have to prep the lesion before we put a stent in there. Otherwise, once you, like PK talked about, once you stent it, it'll be harder to expand the lesion because we can't go that aggressive enough. And then
Can you
it's might-
scrub out and
more.
find out the patency rates of balloon angioplasty in the subclavian?
Sure.
So we're going to find out the statistics on patency rates of the subclavian here, because I think it's important to understand how balloon angioplasty does in the subclavian alone, in the historical data. And then we'll take it from there. Because remember, it's a very large vessel. Fix the sheath, Ray. All right.
Yeah.
8O balloon now going in. Okay. So now the beauty is we have the lima marker, so we know exactly where the lima is.
Yeah.
It's all attached. Everything ready. It's going to go through a 7 French sheet.
Yeah, it goes. Every shockwave goes through 7 French.
Yeah.
So 10
You got it?
Yeah.
Okay, so we're going to, ready, rail?
Yeah, go for it.
Mm-hmm.
One second. Pick up.
Okay. I think we're across the lima there. That's fine. I can go further a little bit if you want. No, I think we're good.
No,
right?
no,
Not go, I would not
I think
go.
we're good.
Yeah, I would not go. And we can shockwave it too and see how it does.
I know. I'm gonna walk the sheet back now. Hopefully we don't have the same problem we did last time. Okay, good. Go up.
The inflated balloon, you can push it.
Of course. Okay, going up again. We're gonna shock across again.
Yeah.
So we're keeping the IVL across the lima.
Yes, we are. Well, we did the first time too. Okay, shock.
I don't like that.
Yeah, just keep it at 2 and see how it works. Even in an 8O, you can. I think this should work well. And like I said, we can do an IVUS and an angiogram, and then like PK can decide whether leave it as a PTA versus.
Go up to 4 and then go up again.
Yeah, it opens up.
You can see by the pressure, there's now no flow in the brachial, so clearly we're one-to-one sides, at least we're obstructing flow.
What's the ACT? ACT?
One more.
One more?
We'll do one
Yeah.
more.
Maybe hang it back a little bit more, bring it more into the aorta, spare that the
Distal edge.
subclavian.
I think, it's expanding nicely though so far, so we'll see how it looks.
Yeah.
I agree with you. It's at a bend. Yeah, I agree with you.
And that deflection that's happening at the distal edge of the balloon, you see it tenting with the subclavian.
You want to IVUS after this?
Yeah, I think we'll IVUS after this to get us a good idea.
All right, get the IVUS ready, guys.
It's making me nervous, just like it's making you nervous, Raman.
Yes.
One second, okay.
I want to see the hemodynamics.
No, the hemodynamics are going to be good. I'm not worried about that. The
It's a
pictures,
PTA, right, Vishal?
yeah.
It's going to be good.
I know.
The picture and the
Yeah,
IVUS.
Leave it there
Yes.
for now. Pull it out.
And
Let's see if it
this
pops
is
up.
one of those scenarios where we say, let's not do IVUS. I don't want to see.
There you go. Okay. Walk it out.
I was overreads, huh? All right, let's see.
So here we have the gradients for those.
I think he's still pulling the balloon.
It fell back, though. It fell back again. So it's hard to track it through that ostium because of the tortuosity.
Yeah.
We'll do an IVUS. Push forward. So the gradient is a lot less right now. It's about maybe 7.
I think that's
So
good.
so which again I think let's now hope that everything looks good. All right, sir, take a deep breath in and just hold it.
All right. The moment of truth.
I think we're done, boys. I think we're done.
Let's IVUS it.
What happened there?
Huh?
I mean, it's the gradient is exactly no, it's still significant. It's
still
20.
significant. It's
Still
20.
20. I thought it was
Yeah.
10. No, it's still significant.
I was.
So let's IVUS. Let's now take a look. Luckily, like all the things we worried about, nothing happened, like dissection and thing like that. So therefore, I think the Lima still got great flow, and now this is a good view to stent too, guys. If we need
Correct.
to,
It's a beautiful
You
view.
know?
You can see the Lima takeoff, vertebral takeoff, and the lesion right in between.
we'll zero both, and we'll do a better gradient. But I
Yeah.
think it's significant.
So now the question really arises is, I'm sure you're thinking and probably almost mentally committed to put a stent in.
No, I wouldn't say that.
Okay.
I just still
Karthik,
wouldn't
your
say that.
thoughts?
I am mentally prepared to put a stent in even before.
I was just
Karthik.
trying to poke PK.
Yeah. Karthik has been calling for a stent for the past 15 minutes.
Karthik's like the case would have been done.
I'm like,
Also, I mean, no, but all things being said and done, I mean, this is not a case that you do want to kind of like mess around for
Exactly,
a very long
right?
time,
That's-
right? 'Cause
that's
you have
my
a
point,
Lima,
Record.
we want to get an answer and treatment as quickly as you can.
Yeah.
Because the last thing you want to have a Lima dissection, this and that.
Correct. So I think that's a very good point that Raman breaks up, is we're trying to be conservative and not being super aggressive at the same time. We started with the 6 balloon, like
Yeah,
you said.
we
Yeah, we
whichever
got a
balloon
stent
you
right
take.
there. You see that? You got a stent. I agree.
Yeah.
Yeah.
And then we got an aero balloon. We still don't get the gradient down. Now, if you go higher up, then the chance of dissection there, which means you have to start thinking about putting a stent in for sure. So I think, and the IVUS is definitely
What's the
showing the same
size
thing.
of the
So
vessel?
I think just going stepwise
have to
fashion,
do a 9-0
is,
stent.
it probably plays safer in this
9.0
case. with
short
hopefully,
Omnilink, 9.020 and
better
9.018.
outlet.
you want to do self-expanding big?
Self-expanding versus balloon expandable. I think balloon expandable is
No,
important
balloon
to the precision.
expandable. Yeah.
What is it about? What is the patency though?
So that's why in this case, since you're now committed to your stenting,
I
you
don't
can
think
be a
we'll
little
need it. I
bit
think
more
we'll be able to go.
aggressive in your balloon. Maybe, like you said, take a short, another balloon 9020 or
So-
whatever it might
so
be, which
why
doesn't
don't
extend
you put
across,
on your
get
stuff and
aluminum
come on
again
in?
and you stent it. If you already know you want to stent it, that's what I would go.
Well,
Yeah.
Dr. Watt has some interesting data to talk about, as always. We're always data-driven, all of us here in the Cath Lab. So let's, I know we don't have enough data to make a lot of our decisions, but what we do, we try to use. So he's got some interesting data. We're going to have him mic up again. Go ahead, Awad, we can hear you.
Yeah. Yeah, so we were just looking up patency rates of subclavian artery stenting versus balloon angioplasty alone. At 1 year, the patency rate of stenting is in the 90s, low 90s, versus mid 70s for balloon angioplasty alone. But over a 5-year period, it tends to even out, and patency for both is in the low 70s.
So you notice, so you have the early recoil with stenting, but you don't have with balloon angioplasty, you don't have the intimal hyperplasia. With stenting at 5 years, you obviously get the intimal hyperplasia and restenosis. So that's the ballpark here. But here we do have a gradient of 20 with Lima ischemia. So I think we need to give him relief of his ischemia. And you notice he had chest pain while we were working. I got the catheter. We had chest pain while we were working. So I agree here. We're gonna have to place a stent and pray for the best here. All right, what do we got in terms of our stents?
Yeah, let's.
All right, we have an
what are the
8019, 8019,
919 and
9019. I'm
929.
sorry, I don't have my glasses on.
If you're using OmniLink, I would.
Yeah,
We're gonna use
OmniLink.
OmniLink.
Yeah, OmniLink. 929 is a good stent. 929.
I think that's a good size. Balloon expandable, non-covered.
So,
Stent is probably the best
guys, the
strategy.
question is, let's say if we compromise the vertebral, hopefully not, but I'm eternally optimistic normally. But so if we compromise the vertebral, how would you guys go about doing it? Just bail out stenting?
Well, the idea here is, let's see the last picture. In the
Correct.
last two angioplasties, you have not compromised the vertebral.
Yeah. So now the
So
chance.
it's unlikely, I
Correct.
think. But the ostium looks very good. I don't know what you guys think. I could wire protect it, but there's a third wire.
No, I don't want it. It's
The third wire.
I think the like you said, if there's a significant compromise, like there's a real slow flow, then I would probably rewire if I have to. But in this case, like PK said, I would not touch it anymore, make it more complex and not touch it. We just balloon it or we just stent it and hopefully we get away from it.
Devil's advocate, Roman's going to say no, but I want to just throw it out there. Do I go with a 9020 balloon and try to get rid of this gradient?
You have a balloon expandable stent.
the stent is on the wire, though.
I'm stent's on the wire.
Stent is on the wire, though.
Listen, I gotta ask. I'm asking. There's nothing wrong with asking.
No,
right?
it's okay. Yeah, that's a
Roman's
good
rolling his
thought.
eyes like,
See,
forget it.
actually, the
I said
osteum.
I was
David, what do you think,
discussing
David?
the same thing with Roman.
David, you be the tiebreaker. David, what do you think?
Well, actually, an interesting recommendation came up from chat about drug-coated balloons. I know we have probably sparse data there, but what's everybody's thoughts on that?
That was my
that's a
initial
no.
thought.
That's a no.
But
All right, why is it a no, guys? Let's talk a little bit. We have a few minutes, so let's talk a little bit about the drug-coated balloon. Vishal, Raman?
Yeah, I mean, so first of all,
let's do
it's
roadmap.
obviously not. There's no data in this territory. And I think it's the time period that we're talking about is we know that this drug technology very likely is going to be effective in all these different vascular beds. But right now, our biggest concern is embolization, protection of these other branch vessels. So going in with the therapy that with known embolic disease potential, I think is a little bit it's less conservative than just a PTA alone, I would say.
There.
I think just given that extra risk. And I think also just, again, this is a guy who doesn't have upper arm claudication.
coronary, guys?
Right? He has
Coronary?
ischemia. So I think going with the safest of the treatments, whether it be stenting, which probably is, and then versus PTA. I think the drug-coated technology in this particular spectrum is not really studied enough.
Correct. I mean, that's true. And plus, remember, we did the PTA. We saw there is some recall. We saw that we didn't abolish the gradient. We saw that there is still calcification, which is significantly compromised at looming. So the DCB is not going to give me that scaffold, not the radial strength, which a stent would in this case. So even if let's say somebody wants to be do it at an off-label and do it, this is not the case to do it because post 2 PTAs we haven't seen as improvement as we expected. So DCB is not going to give me any more gain than just lining it with the drug. So here we need a scaffold. We need some radial strength to keep the vessel open. So that's why, and of course not being stunning at all with the embolization potential going up, going down. There's just too many moving factors that inhibit me from using the DCB per se.
Yeah,
Did you guys use a 29 or a 39?
29.
29.
All right, little die.
Oh, that's long.
Yeah, sometimes 29 looks so long, but the 19
I
not
think
so
that's
much.
good right
That was
there.
good.
That's good right there.
Let's go up.
Take a picture. What?
Okay.
Can I see?
You can go across that marker.
Yeah, you can go
little bit.
across even more.
Yeah, remember the stent
Marker
starts
a little
just
bit.
before
Yeah.
it too, the markers.
And then it's going to
That's good to
flare
get.
and it's
That's
going to
good
lose
to
some more.
That's a great spot.
Little die.
Yeah, good die.
Yeah, that's a
Okay,
good
going
spot.
up.
Yeah,
You're
good.
still
You
can go
okay?
in a little bit more. I think.
That's good.
Okay, well, now we're going up. So.
So there's the
Sorry. Sorry, Raman.
nice.
What's nominal? What? Guys,
7.
Whatever. He's already come down.
careful.
Yeah.
What's
Let's
nominal?
see.
Yeah, he only went 6.
Now I'm
7?
11.
11.
Okay.
Nominal.
11 down.
Wow.
Still tiny. Guess we can finally open up that 9020 balloon then. You guys.
This is the 9.0.
This is the 9.0, so we have to use a
9.0
10.
stent.
This is a 9.
Mm-hmm.
Good.
Okay, hold on now.
Now get the sheet before we have to do the.
Wait, hold on. Are we on coronary, guys? Am I on coronary?
Yes.
Inject?
No, I just want to go into the stent.
Yeah, he wants to track it.
Okay, good. Now walk out the balloon.
Gradient is almost gone.
Mm-hmm. Mm-hmm. Gradient is gone. Okay. Go forward. Stop flushing. Okay, the gradient is pretty much gone. So 140 looks like. Still a 10 millimeter, 8 millimeter.
That's fine.
8 millimeter gradient.
All right, DSA, guys.
Excellent.
Okay.
1 second.
Took a 40 millimeter gradient and made it it looks like right here at 12. So
We have to
all right.
re-zero everything.
All right, we'll re-zero everything. Sir, hold your breath, sir. Hold your breath.
Beautiful.
I like it.
We
There's
missed
no
that.
sluggish flow across the vert, which is good. You know, it's quick.
But I think it's still going enough
That
for
area
not
is
to
right
do
across
anything.
the...
Yeah.
I mean, look, right now we're going to re-zero everything. Let's re-zero, guys. Let's pull the wire out
The
of the
lima flow is
Yeah.
beautiful. The word flow, the osteum, the anatomy still is maintained. It's like it hasn't kinked to the opposite side where it could
Re-zero.
compromise it. So I think
You see that there's still that nugget that's
Correct.
just right contralateral
Right
to that
across to the
takeoff.
Lima, yep.
that nodule will keep sitting in.
But we are looking at the pressures. There's no significant gradient. You know,
So now I've zeroed both
less is
guys.
more.
And look at that, no
gradient at
no
all.
gradient.
No.
So I think we're done.
I mean,
You want to re-IVUS it?
only thing I'll just say is that
We're
you know,
gonna-
I know that
we're gonna
approximately the
re-IVUS now?
vessel is an
pull the
11,
wire
and
out.
we have a 9.0
No,
stent.
change it.
Okay.
We're maybe just flaring the ostium to make it more one-to-one with the proximal
You're already engaged with the sheet. No?
subclavian.
Just wire it.
No. We're going to re-IVUS it, guys, and we just change out the wire. I'm just going to be a little conservative. I don't want to get under a strut because of what Raman said.
Yeah,
I agree that with the wire, we're not one-to-one and proximally, and the idea is maybe we are, maybe we're not. Let's double check with an IVUS and decide. So we're just going to go in with an 018 wire.
The gradient is not
Gradient is gone.
gone. Completely gone.
So this is a good example for those at home. I mean, obviously, stenting is the final answer for majority. But again, you saw the data is not very impressive with stenting in the long term, as Dr. Awad nicely showed. So I think that here the idea here is at the end, it's like there's an old saying, right? Either you poop or you get off the pot. Right here, the pot is the Lima ischemia, and we need to make sure that we get rid of that ischemia so the patient is feeling well while not creating a problem with the vert. So here with the vert, I think a couple of principles I think all of us would agree as cardiologists, but for the vascular surgeons and the radiologists at home, if there's no significant osteal disease in the bifurcation point, generally speaking, you don't have to wire protect, but obviously being a dominant vert with the risk here, we decided to wire protect, but when it behaved just fine after balloon angioplasty, we decided to pull the wire out. Actually, the wire fortuitously came out. We left it, and as you can see, the entire case was done without a wire, and everything is, thank God, fine. So now the idea is, there's an old saying that my mentor and all of our mentors, Dr. Sharma, used to say is don't get crazy. And I think here the idea is, yes, if the stent is malopposed tremendously, you could want to balloon dilate, but if you put a larger balloon in the proximal, you could plaque shift into the vert, you could create proximal dissection. So you got to weigh the risk and the benefit. You got rid of the ischemia, your patency rates are pretty good with the newer, especially the cobalt chromium stents, because the old stents that Awad was talking about were stainless steel. So let's see what it is here with this IVUS, and then let's make a call together as a team, as we always do. So, okay, so here's the 018 IVUS going in. And again, Raman pointed out the nugget, as he calls it, the nugget distal. So we'll ignore the nugget, and we'll come forward with the IVUS. Okay, ready, guys? Go live for the team. Recording.
We're live. Yeah.
So the nugget will come very soon, as you know.
No, it's eaten up.
There's a nugget right there. Nugget. There's a nugget. Lima right there. Little lesion, but there's a stent.
That's a little bit oral, yeah.
I think we're good.
We're good?
Yeah.
We're good.
Okay, I think we're done, guys.
No,
So if you guys are okay, we'll take some final shots here and end the case. And thank you so much for the wonderful moderation. David, thank you for being the virtual moderator for the first time. I thought you did a phenomenal job. And Nawad, great job. And we'll sign off and thank all of you guys from the Cath Lab. Hope it was a useful case. Thank you, guys.
All right, guys. Thank you again, PK, and everybody in the room for another excellent case. A great discussion. It's always nice to see a bunch of attendings disagreeing with each other. But this, I think, is just another demonstration of how a somewhat simple case, if you really look into it, is really not that simple. So here from Mount Sinai, thank you again for joining us to start your day off, and everyone have a great day. We look forward to seeing you next month for our pre-Thanksgiving special on November 19th for our next live case broadcast here from Mount Sinai. Take care and have a great day.
Have a good day.